Welcome to Thailand. I think this is not your first time to Thailand, right? Who is the first time in Thailand? No. Yeah. So you can call me Bancha. My last name is too long. Chernchujit is too long. So call me Bancha. In Thailand, we always call the first name. So I'm working in Thammasat University Hospital. So it's a hospital in Bangkok, but not in the center. It's on the border of Bangkok. And I'm working as the shoulder surgeon and sports surgery. So my focus is shoulder, everything about shoulder, trauma, arthroplasty, arthroscopy, everything about shoulder, right? So we're talking about the AC joint. We can try tomorrow. AC joint is very interesting joint. It's a small joint, but there's more than hundreds surgery or procedure. So that means there's no final solution for the AC joint. We can try in the lab tomorrow, okay? So good. Now I'm talking about the shoulder, reverse shoulder arthroplasty, okay? So my fellow Dr. Sun, can you help me to change the slide? Yeah. So thank you, Chris and Dr. Siu, for your coming. And yeah, this is our pictures. So fast. Yeah, this is our selfie picture, and also thanks, Christy. So we will have the meeting with Hong Kong and China this year in Pattaya. Yeah. So this is our combined ARCOS, COA and HKOA meeting with the president, KK Wong and YK Chan. So in this meeting, we have the first workshop on the beach. Yeah, so we put the cadavers to the workshop, right? So we have 3 workshops at the same time. So one is shoulder workshop. Yeah, just talking about the shoulder instability. So we have a big name from China, from everywhere. So this is the first workshop, and the second workshop is robotic. Yeah, it's not our job, robotic, kidney arthroplasty. Another workshop is about the trauma masterclass. We're talking about the typical trauma, pelvic acetabulum and lower limb, trauma about plateau, something like that, yeah.
And faculty work.
Yeah, right.
I'll be popping both of you.
That's right, yeah, you'll be there.
Yeah,
so please take this picture. If you're interested, you can just scan, and yeah, we are very happy if Hong Kong friends will come to join our meeting. Yeah. So this is the first time we organize the workshop on the beach. Yeah. Yeah, this is our website. You can go to the arcosmeeting.com. Yeah. So, and you can scan me. WhatsApp is better. Yeah. You have any problem, just text me. Yeah, I can facilitate. Talking about the indication for the reverse. So right now, previously, reverse is designed for rotator cuff arthropathy, right? But right now, you know, the indication of reverse is become more and more, right? That's including proximal humerus fracture. Right now, you know that the hemiarthroplasty outcome is not good because you cannot guarantee the tuberosity healing. So the reverse outcome is better. That's why if the patient, elderly patients, and poor bone qualities, the reverse better outcome. So we can talk about that in the lab tomorrow. Okay, we can show you how to make a tuberosity fixation or reverse in fracture. Okay, that's not the same like routine reverse. Okay, and also we're talking about the non-union because we have many non-union patients, neglected non-union in elderly or neglected dislocation anterior and posterior. Yeah, because any procedure cannot have a good a solution. Yeah, so we can show you the case, and also the OA shoulder. So OA, previously we do the OA shoulder in using anatomic replacement, but we found that in very old patients they have poor cuff quality. So I'm not sure in your practice. Right now I think it's more common because once we do anatomic shoulder replacement, the patient have already thin rotator cuff, okay? But over time the cuff gone, then finally they cannot elevate. So if you do reverse, you don't need to worry about the future rotator cuff, right? And some bad severe electro version, more than 15 degrees, you do anatomic replacement, the glenoid getting loose very fast. So that is my indication for reverse. So extending from the past, okay? So you have anything, some tumor guy do reverse in tumor also. Yeah, you have the resect proximal humerus. Yeah. So those are the, I think, current indication for the reverse shoulder arthroplasty. Yeah. So we're talking in details about the patients. This is like 89 years old, 6 months of shoulder pain. Once you see this picture, I think it's clear that the patient have arthritic change and there's no rotator cuff. Yeah. So I think this picture is very, very useful. So for me, this picture is enough to do the surgery. Okay. Sometimes we don't need the MRI because you guarantee that the cuff is all gone, right? Okay, this is her examination. She has a pseudoparalysis and all the cuff is gone except subscapularis. Okay, for me, if you're going to do reverse, if you have good deltoid, you have good subscap, you have good teres minor, that's enough. Okay, for me, 3 tendons. You have no supra, infra, but you have good subscap, deltoid, teres minor. That's enough, right? So we can discuss about the approach. Yeah, that will be deltopectoral or deltoid split. But for me, previously I do the deltoid split. Right now I change to do the deltopectoral because we have better exposure. So for subscap, I prefer to peel off. Okay, I prefer to peel off because I can reattach it later. Okay, this is the arthritic chain. When you get it, so you have nothing on the top, you can easily dislocate the shoulder joint, right? So this is the cut. For the lateral version, I prefer the native version of the patient. Yeah, so this arm will be parallel to the patient forearm, right? Okay, and then protect it like that, and then we do the exposure. I think this step is quite important. Yeah, for you, for the beginner, you need to know how to make the good exposure. This is the most difficult step for the reverse. Okay, so make sure that you have. Okay, and also the pin, it should not be in the center. Okay, it should be lower. Okay, to prevent the reverse. And I always put the bone graft. But right now, Zimmer have the augmented base plate, right? But previously, this is the original one. We always put the bone graft on the top. And for Asian side, I think mostly we can put only 3 screws in the center. Yeah, because the AP screw always very short. So for me, I put only 3 screws. I'm not sure how about you.
Yes.
Chris, yeah. Yeah, mostly I put 3 screws. The center, the 12 o'clock and 6 o'clock screw. Yeah. And then for the subscap repair, I always put the suture loop around my stem like this. Okay. And also I will put the bone graft, okay, to the proximal to prevent the villus. Yeah. So my bone graft we put on the medial side. Okay. That would promote the healing. Yeah. That is the trick. So when you do this, that will make your stem very stable. Okay, and also enhance the healing and prevent the villus deformity. Yeah. So so for the humerus, okay, that is, and also I will put my bone graft on the tuberosity and put the stem in the polyethylene. Yes. For the thickness polyethylene, I will check the stability. I did not mention about that. I will track the humerus, try to reduce. If I found that the cup is about half of the glenosphere, that's enough, right? And that is my subscap, yeah. So I always make a good release of subscap and prefer to repair subscap back. Okay, so this is my suture bridge technique using the suture will loop around the stem. So that will be very stable, okay, and make it like this way, yeah. This is like suture bridge, it's cruciate like this, yeah. So they have better contact and make sure that the patient have good motion, okay. And check your Septic vein always, because many times after surgery, when you traction for many, there's some laceration. If you did not take that, the patient will have hematoma. Okay, always checking the septic vein, always after the surgery. Yeah. So that is my way of the reverse in cup arthroplasty. Okay. So I want you to have the question and sharing, please.
Some of the, I just want to ask about, do you always repair the subscapularis in every case?
Yeah, a very good question, because this is controversy. If I cannot repair subscap, I will not. So first, okay, like if the patient have the chronic contracted subscap or in fracture sequelae, for example, subscap quality is very bad. So after I process in and I try to reduce subscap back, if I cannot, I will not do the subscap repair. Okay, because those patients will have very bad subscap. But you try to release the subscap first. The trick is that number one, you cut the rotator interval, because subscap attached to the supraspinatus, right? You need to cut it separate. Okay, you cut the rotator interval, and then you release coracohumeral ligament because it's attached from subscap to the coracoid. So after you release, and then you try to pull the subscap again. In this position, neutral position, slightly exrotate. If the subscap cannot reach the lesser tuberosity, don't repair it. I have one patient referred from another surgeon. They repair the subscap, and the patient come to see you like this, contracted. Patient not happy at all because he cannot external rotate. Yeah. So the concept is that if you can repair subscap without tension, I repair it because you provide better stability, okay, and also better function. Okay.
And concerning the rehab, would it be different between the one you have repaired subscap or the one with?
Yeah, that's depends on the interval. Like I show you, right? After you repair subscap, you test again how much you can go, right? If you can go 45 degrees, so you can let the patient do slowly. Yeah, motion. Yes.
Just raise your hands. How many of you has done RSA before? Hands up.
Yes.
How many of you have not done one case before? Yeah, so some are. So I think we have to start from the basic.
Yes.
Just to rephrase everything again.
Right.
So everyone is on the same page.
Yes, right. Okay. So that is for the, I say in the rotator cuff tear or cuff tear arthroplasty. Okay. So that is the first indication. So this is another indication. He is 70 years old, massive rotator cuff tear, infraspinatus. Okay. So this is the X-ray. You see the cutaneous, right? So you see the infraspinatus and the supraspinatus is very bad, right? So the patient referred to me because the doctor who referred to me said this patient wants to have the tendon transfer. Okay, I discussed with the patient. We can do tendon transfer for you, but I'm not sure about the outcome because you have bad supra and infraspinatus. We can do like lower tract transfer or SCR, but the rehab and also the recovery will be very delayed. Yeah. So I discussed with him. He said, and he don't want to have the fail. He want one surgery. I told him that if you do some tendon transfer, you need to accept the failure because you need healing process, right? So I give him the option. He's very active. He play golf. Yeah. So I discussed with him. This is his function. You see, pseudoparalysis can elevate, and also external rotation leg size is positive. Belly press is good. Yeah. So I discussed with him that I will do reverse for him. Yeah. So same things, repair subscap. Okay, you see? When you repair subscap, make sure that you have good mobility. So release first. Don't just repair it. Because many times when you repair the patient subscap but no function, okay, the patient will not happy and they have stiff reverse arthroplasty. Okay. So this is a X-ray. Yeah. So he happy and come back to golf again. Yeah. So he sent me the video after the surgery. Next. Yeah, this is his swing. Yeah, he's happy.
Slow motion.
Yes. Because he said golf is his life. Okay. Go back to the X-ray. Yeah. So once you do the reverse X-ray.
X-ray.
Next. Previous. Yeah. So I tend to make this prosthesis a bit lower, and inferior tilting. And the simple biomet have the offset. Yeah. So you can make the offset overhanging because the failure is because you did not have enough overhanging, or you did not have enough inferior tilting. So the concept is that you should have inferior tilt enough to change the shear force to be compression force. Okay, and overhanging is preventing the notching. Okay, so and nowadays I think I prefer not to use cement. I'm not sure, Chris and Dr. Phil, you.
Very simple. Fracture,
Yes.
cement. No fracture, no cement.
Oh, that's your concept, right? How about you?
In the old days, I tend to use cement, but now 90% of my kids use cement as
Cementless.
yes.
Yeah, I agree with you. 20 is no cement. But for the fracture, I also know cement.
Ah.
Yeah, I will share with you how to make it cementless. Because in fracture, I know that when you put the stem in, you feel like it's not stable enough, right? But we have the way to make it stable. And we found that if you use cementless, because you know cement is good, it's immediate fixation, but it's very difficult for you to revise, especially proximal humerus. I have ever revised many cement, I broke the humerus many times, okay? So for me, I try not to put the cement, but you need to know how to make it stable without cement. And we can discuss with that later, yeah? Very good. And sometimes you need some, the tendon transfer if the patient have no tendon or no teres minor, okay? We need to, sometimes need to reattach or using some graft to make it stable, yeah? Okay, next. Next one. So this is the concept that you need to know for the glenoid. Number one, you need to have very good exposure, okay? So if you did have enough exposure, you should make it good exposure before you proceed. Because most of the complication is coming from glenoid. You agree, Chris?
Not for me,
Yeah.
fortunately, but I pay a lot of attention to
Yes.
glenoid, so complication rate is low.
Mm-hmm.
So far, most of my complications are humerus.
Or humerus, right? Yeah. So most, in my practice, most of the patients that fail is because of the glenoid. Because most common is that they did not have enough exposure. And they put the glenoid too high. They put it too high. Once you have it too high, the notching will, the patient, after surgery, will have notching. Another way thing is that they have not enough tilting. Yeah, if you have not enough tilting or not enough overhanging, they'll be slowly unstable and then dislocate after the surgery. Yeah. So, and next thing is that you should have enough overhanging, yes, and inferior tilting. Make sure that you ream inferior more than superior. Once you ream, you can see the bone like smile in the inferior part of the glenoid, okay, and proper glenoid size, yeah. So now we can make reverse smaller than the smile. Oh, this is my fellow idea. You can make it smaller because right now, but if you're the beginner, you start with big incision first. Okay, don't concerning about cosmetics. Concern about the outcome first. Okay. So the technique that I prefer for my reverse is that when we put the stem in, like I show you, we put the bone graft on the middle side. And I prefer to make it like when you trial, okay, you trial like you count 10 millimeter, I go to 9. I make it smaller, but I pack the bone graft. Because for the proximal humerus, I don't need, it's not like hip, you need to make it very press fit. I make it a bit smaller and you have less chance of fracture. Okay, I make it one size smaller and pack the bone graft. I prefer this 3-point fixation. You see that my stem is a bit valgus, okay, and this is my 3-point fixation, okay. And I prefer proximal fit or metaphysical fit because you have less reduce the state shielding at the tip. If you make it very fit to diaphysis, you tend to have fracture, okay, in the future, okay. And we pack the bone graft on the medial part of the prosthesis to improve the healing and make the stem valgus, okay, and prevent the GT fractures or resorption. Also pack the bone graft because here you will have some holes on the proximal. Can you point here? Yeah, this area. So this area, after you put it, there will be the big holes here. Yeah, I also put the bone graft in this area to make my tuberosity stronger because I have some patients have broken tuberosity after the surgery. Yeah. So this is your questions about the subscap. Yeah. So I prefer to repair if it's possible. Is there too much tension? I just leave it to provide better stability, improve internal rotation. Okay, but it's still controversy. Yeah. Okay. So the medialized lateralized system for the simmer, I think it's become more popular. The grandma or medialized system become less popular because you have the higher chance of the impinging or notching. Yeah. And also the morphologies of the deltoid, you have less deltoid wrapping effect. The patient deformity, I mean, after surgery, it look not nice. If you use a medialized system, you will have like sulcus, you have the flat deltoid. Yeah. Okay. So we prefer this system. Next. And for subscap repair, I just showing you, this is we call the TUEX technique. We propose this technique. So it's very simple. You make it like this way, right? 2, 1, 2. 2, 1, 2. So you pack the suture in, and then when you tie the knot, it becomes like E, and then X, okay? So that's a very, very nice and very good contact, yeah, and we found that the outcome of the healing of this TUEX technique is very nice, yeah. Okay, I'm showing you how to do that, yeah. So we drill the holes, right? We have the lesser tuberosity. We drill the hole medial to the lesser and the groove and lateral to the hole, right? We make 3 holes, okay, and then we put 2 sutures, okay, Echelon number 5, and 1 sutures like this, and then 2 sutures, and you put the stem in the middle and pack the bone graft like that. Again, you pack the suture in. Okay. I put the loop. This is a PDS loop. Can pass the suture in to the subscap like that. Okay. And after that, you get the 2, 1, 2. You cross. You repair it like E first. Like that. Okay. This is, you see, 3 suture is like E. Okay. And after that, there's 2 suture, you just cross it to be X. And we did the mechanical study, we found that it's very strong, and also you have better contact. Yeah, we put the Fuji films underneath, and we found that it's have better contact between the subscap to the, it's like you repair rotator cuff, you should have the contact, good contact. It's like suture bridge. Okay?